I'm Marc Raab from Heidelberg, Germany, and we are here in Edinburgh, Scotland, at the Myeloma 2017 meeting, and we just had a very interesting session on CTCs, circulating tumor cells, and cell-free DNA. The main questions: are we moving away from bone marrow biopsies? I'm joined here by my colleagues Irene Ghobrial from the Dana-Farber, Andrew Spencer from Australia, Rodger Tiedemann from Toronto, and Niels Weinhold from Little Rock, Arkansas. So Irene, you talked mainly about circulating free DNA versus circulating tumor cells and the pros and cons on the two types of analyses and the potential to move away from bone marrow biopsies, basically. So what is your main take on your results that you presented?
Yeah, absolutely, Mark. So thank you for this introduction. I think what's important now is we're trying to ask the question, can we use blood biopsies or liquid biopsies potentially to replace bone marrow biopsies or give us even more information? And as we've heard from multiple talks, including Jens Lohr from Dana-Farber too, we have an option of using circulating free DNA as well as circulating tumor cells. And when we add both of them together, I think we get much more information than just one single bone marrow biopsy site. Again, you'll hear more about multiple sites, but this may be not the easiest thing to do multiple bone marrow biopsies on patients. So potentially, can we use just the blood sample to really understand better clonal heterogeneity, but also multiple sequential samples during treatment? Think about it, we get maybe every month a blood sample on our patients when they're on treatment. We can add to that information by not just doing the M-spike and serum free light chain, but you get the information of what's going on in your bone marrow with a reflection in the peripheral blood. And I think that gives us this unique opportunity to truly understand the disease in a much better and deeper way. And the technology will get better and better, so hopefully we will get more information to replace a bone marrow biopsy.
Yeah, so talking about technology, as you said, right? So there are different platforms, different ways of address that. So Andrew, you have used a slightly different approach, focusing mainly on certain driver mutations, right, compared to some others. Also, Trudel, who was also in the session, did that. So Andrew, what is your thinking about which would be the best platform, and is it coming closer to prime time, meaning to be used in clinical practice?
I think we need to determine what we're trying to answer. I think that the final presentation about prognostication at the time of diagnosis clearly, with present technology, would mandate a bone marrow biopsy. I think that once you move beyond diagnosis, though, into the context of patients who are relapsing on therapy, the utility of a single-site bone marrow biopsy becomes far less useful. And I think that's becoming abundantly evident because of the spatial genetic heterogeneity that accompanies relapse. We look at it from a purely translational perspective. We're not basic scientists, so we're interested in technologies which we can apply in the clinic, hence our adoption of a fairly focused high sensitivity platform, which, whilst lacking, genetic coverage, has got clonal coverage. It reveals lots of clones, as was evidenced with the DNA damage response genes. So we're hoping to be able to bring to bear, more in the relapse setting and monitoring setting, the concept of liquid biopsies rather than at the time of diagnosis.
Okay, and you mentioned already the clonal heterogeneity, also the spatial heterogeneity, so to say. Niels, you talked about this quite a bit with getting a lot of bone marrow biopsies from single patients from different parts of the body, so to say. So what was your main result on that, and if you compare it to what the other speakers have presented on liquid biopsies, so to say, would you say that liquid biopsies, given your results from the multiple bone marrow biopsies, could reflect this heterogeneity in space, so to say?
So that's what we actually expect, that with a peripheral blood sample, that this could be kind of more representative than just a single bone marrow sample. But according to what we have seen in a couple of patients, that actually there are at least 10, maybe up to 100 different clones in these patients. We don't expect that we can actually detect all these clones with a kind of standard test in a periphery. But as Irene already said, our approach is to collect multiple samples from different sites. It's definitely nothing one can do in a routine setting. And what Andrew just said, that especially in relapse patients, that heterogeneity increases. I guess the next step would just be to kind of combine these two approaches, at least in a subset of patients, just to understand what really happens in a bone marrow and what's the relationship to the periphery.
Yeah. I think one of the big points we learned again today is that we still have to learn a lot about myeloma biology. And Rodger, you presented very interesting data that looking at the plasma cell in terms of myeloma cells as we know it is probably not enough. So you showed even earlier cells that do not have all the markers of myeloma cells share or already have genetic features of what we know in myeloma now. And you also even mentioned there may be signs of plasticity. So could you elaborate on that a little bit more? Because that was kind of thought-changing maybe even.
Right. So essentially nearly everyone in the field studies CD138 positive plasma cells as the tumor cell in myeloma. And our data really does suggest that that is a self-renewing, proliferating population. But we can also show that there are rare subpopulations of cells in myeloma that lack that particular marker, as well as other plasma cell markers and plasma cell transcription factors such as IRF4 and XBP1S. And that these other rare subpopulations of cells in myeloma are generally quiescent. And when we try and understand how they interact with the plasma cell population in myeloma, we can show two different types of interactions. We can show that those cells can actually differentiate into plasma cells, but we can also show that if we take purified populations of plasma cells and try and grow those as tumors, that we can in fact develop tumors from those cells, but we can also see some plasticity of the phenotype of those cells, with some of those cells becoming 138 negative and 38 negative and lacking the transcription factors of plasma cells. So we can see plasticity in the phenotype of plasma cells, but we can also see sort of ancestral clones present within non-plasma cells that can become plasma cells with under the right conditions.
And I think you even did that experimentally in vitro, as I recall. So in terms of treatment options, right? So if we eradicate what we know as plasma cells, as myeloma cells, right? But you have still these kind of ancestry cells or plasticity cells, whatever you call them. What would be a good option to treat or to target these cells? Like maybe the now upcoming immunotherapy, probably not CD38 in this case because they don't express it, if I got this correctly. Maybe low expression of BCMA, or could you speculate a little bit on that at least?
I think the phenotype of these cells is really important to understand as we move forward into an era of immunotherapy where we're really targeting cell surface antigens on cells. We certainly see cells that are 38 negative, they are rare. We see cells that are BCMA negative, they are also rare. I think to achieve really deep responses and durable responses, cure, we probably need to target all of these different populations of cells at the same time, because the cells can transition between the different subpopulations fairly quickly, I think. So yeah, I believe moving forward that our approach will be to target all of these different populations and really understand the characteristics of each population so we can target them together but individually at the same time.
So given that, what you just said, and the final talk, a kind of keynote lecture by Gareth Morgan on the clinical or prognostic impact of the small genetic subpopulation, Irene, where do you think therapy in that context will head in the near future?
Yeah, I think it's important because for many years we keep saying precision medicine should be the way to go. And if you think about it, we all talk about clonal heterogeneity, about so many genomic complexities of myeloma, yet at the end of the day we treat all the patients the same way. And it doesn't make sense when you have a high-risk patient getting the same treatment as a intermediate or a regular risk stratification for those patients. So I think Gareth Morgan's really put that whole picture together, saying, let's understand what's happening at the genomic level, but take it into the clinical practice in the future and maybe really talk about high-risk individuals with specific mutations and alterations, and those patients should be treated differently. And I think precision medicine is coming along for myeloma. Hopefully, at the end of this meeting, we can say that we should treat some subpopulations of myeloma differently and expect hopefully a better outcome for those patients.
Yeah, maybe in a different sense as precision medicine originally was proposed. You know, you have one mutation, you treat the patient just because of one mutation. That may work in a few cases myeloma, we know that, but for the majority of myeloma patients, certainly this kind of precision medicine, I think that's what we are going to follow, right?
Yeah, absolutely. And again, there are themes, RAS or MAP kinase pathways look very interesting, so potentially in some patients adding certain inhibitors. I think now we're seeing with the 1114 translocation venetoclax working, so there are some advances in that field now, and hopefully we will improve on it.
Absolutely. So I think it was obvious that this was a very productive, very interesting session today. And we have still to do a lot of work to understand myeloma and to improve prognosis and survival for our patients. Thank you so much.